So welcome to everybody. Thank you so much for coming this evening. As mentioned, I'm Dr. Grace Heisendis. I'm thrilled to see some nursing students here as well as everybody else. So I'm going to start the first 5 to 10 minutes here talking just as a basic introduction and answering that question, why? Why are we sitting here? Why are we talking about Lgbtqia health issues? You know, what's the problem? We treat everybody the same, right? Why do we have to point this particular population and individuals out? And I get that question quite frequently. And what we really need to look at is the evidence that's out there in terms of health data. And we do see disparities. Unfortunately, but true, we see them across racial lines, we see them across gender lines, but we also really see them across LGBTQIA population lines. So because of that, we really have to do something different. We have to bring the conversation to the forefront, but to talk about it and talk about it and talk about it, and then step into the action mode, right? So that we can start seeing these disparities start to decrease. So one thing is, do we see any changes in health disparities within this particular population? One of the things that we do see and talk a lot about is HIV, right? So overall, in the United States, we're seeing a stabilization or a decrease of incidence of HIV, which is fabulous. There are a couple populations and groups of people that we see an increase in HIV. And difficult or complicated to look at outcomes and see any change there. One of those subgroups are men of color, young men of color. So we know there's an intersections with all kinds of different things, and race can be one of those. The other population we're looking at is trans women, so transgender women, and we see an increase in HIV incidence there in some studies. And some say it's stabilized, and others say we do see an increase in that population. So whatever studies you're looking at, we do know there's something we need to do. So from the healthcare perspective, we all have to be really in tune to those numbers and what we can do about them. So some of the other pieces for health disparities are centered around things like smoking and drug use and alcohol use, and mental health, and suicide incidents. And with all of those things, we see an increase within this population that can be associated with a lot of different factors. Another thing we have to be real careful of is not to pigeonhole people, right, and put them in boxes. So we might have an African-American lesbian woman who's never had alcohol, who's never had a suicide ideation, and doesn't smoke, right? So again, when we talk about populations, individuals, and patients, there are these tendencies and these risks, but that doesn't mean that everybody falls into that category. So individualizing your patient care and your patient plan is really, really important, of course, for everybody. But there are some things you have to be aware of. We're not real great at doing a sexual history here in West Michigan. And you can probably guess some of the reasons why that might be true. It's a little different in metropolitan areas like New York and Chicago and San Francisco, where sexual health histories are obtained much more frequently and much more accurately, and everybody present. And here in West Michigan, we have some challenges. So we have to be aware of that in healthcare. If you're going to move into practice here, you really do need to know sexual history, how to ask questions, how to communicate with people, and how really to start looking at how we collect that data, how we record it in our electronic medical records, right? And then what kind of outcomes are we measuring for populations, and what can we do to make a difference? So healthcare and how you're educated, how you educate those around you, and how you educate and work with your patients is really of essence. And one of the key pieces to also look at is belief systems. right? So we all want to say we practice exactly the same for everybody, and it's equal, and we don't have any bias, we don't have any stereotypes of how we practice. And if I asked all of you that question, 100% of your hands would go up and say, yeah, that's what I believe and that's how I practice. But when we look at the data, we really see that that's not true. So what you believe to be true and how you practice, and this is true of nursing, physical therapy, across the spectrum, you practice in a different way. So how your beliefs are formed actually influences how you practice in your professional world. And now I realize after talking so much, I didn't turn my mic on. There we go. There we go. So, really important for you, everybody in this room, and for you to extend that to people that you're working with, to do your own self-reflective work, right? And to say, what are my belief systems? How did they get there? And how might that influence the practice that I give to my patients and the care I give to my patients? So, let me make sure that we're covering the pieces that are important. Okay, so for your patient and your being very comfortable with a sexual health assessment, right, in terms of this particular population, and also knowing risk factors, and one of them that are Healthy People 2020 and the IOM, which is the Institute of Medicine, what they have said is that we know with, for instance, adolescent populations, that we see a much higher suicide ideation and risk, and actually practice all the way through. And we see that definitely with our transgender population as well. So knowing that and incorporating that into the plan of care for patients that come your way, really in essence, all right, to know what the national agendas are, to know what the risk factors are for our populations, and also to know where the data is. It's really easy for you to access with your practice and your patients. One of the sites you can go to is the National LGBT Health Education Initiative. And all you have to do is Google Fenway, LGBT. All kinds of health information comes up for you when you're in situations with individuals and populations in this particular area. So thank you, and we'll turn that over to the next person.
All right. So again, my name is Jen Sue Bishop. I use she, her pronouns, and I work in the Milton Ford LGBT Resource Center. One of the things that I was asked to talk about a little bit today, and I know I see some familiar faces, so this might be a refresher for some of you, is the definitions for the initialism LGBTQIA+. For the sake of our folks who are joining us through live stream, this is going to be fairly painless for you all in person. What I'm going to ask you to do is help me with the word that the letter represents, and then I'll give you the definition. Does that sound all right? So, L, what does it stand for? Lesbian. Wonderful. So, we use a really simple definition, and that is an individual who identifies as a woman who is romantically or sexually attracted to other people who also identify as women. Pretty simple. What about the G? What does it stand for? Okay, awesome. So a lot of folks, right, given that first definition, will oftentimes say an individual who identifies as a man who is romantically or sexually attracted to other people who identify as men. Absolutely correct. But you also have a sense that sometimes we use this language to mean that they experience same-gender attraction, right? And that's perfectly a-okay. And so sometimes this language might have a little broader connotation, but similar meaning. What about the B? Bisexual. Awesome. So bisexual is a term that has a lot of different definitions, and one that has actually shifted quite a bit in the last few decades. So some people may use this definition that says an individual who is romantically or sexually attracted to folks who identify as men or women, and that's what the bi, right, to means in bisexual. But we also recognize that that can be a little limiting. Recognizing that binary of men and women doesn't capture all of the experiences that people have with gender. And so for some folks, they've re-signified bisexual, the to and bi meaning my gender and whatever potential gender the person that I might be attracted to, and those being the two genders. To be more inclusive and expansive, to recognize that bisexual individuals may be attracted to people who identify as non-binary, agender, gender fluid, etc. You may also hear language like omnisexual or pansexual. These are other terminologies that may feel more fitting for folks and less constricting than the term bisexual. How about the T? Transgender, awesome. We use a really simple definition that says an individual who identifies somehow differently than the sex they were assigned at birth. And so this means that an individual does not have to undergo any sorts of social, medical, legal transition in order to identify as transgender. They simply identify differently than the sex they were assigned. So this might be an individual who was assigned male at birth who identifies as a woman, or an individual who identifies as non-binary who was assigned female at birth. So any combination of identities that somehow is not aligned with or the same as the sex assigned at birth. How about the Q? Queer, awesome. I can tell some of you are really on it today, so thank you. So queer being intentionally difficult to define. At Grand Valley, you can get an LGBTQ minor where the Q stands for queer. We have a faculty member that does research around queer criminology. And for a lot of folks, queer simply means not straight, not fitting into the binary, and potentially not cisgender, which we'll get to in just a little bit. I think we'll talk about that in the video. And so queer is intentionally difficult to kind of put in a box. And so oftentimes resists being put into kind of simple categories of straight and gay or other things like that. And there's also different ways that the Academy has really adopted and taken on queer to apply to different fields. And so if you were to queer a text, for example, it might mean to actually read against the grain of the main plot or what the author may have set out for readers to understand. And so queer has a lot of different meanings, but when we're talking about identities, oftentimes it simply means not straight or not cisgender. How about the I? This is a stumper, huh? All right, I'm gonna give it to y'all. So I stands for intersex. There's a really wonderful definition that we use from the Intersex Society of North America that says that it is a socially constructed category that reflects real biological variation. I know it's a lot of big words and concepts, so I'm going to say it one more time. So a socially constructed category that reflects real biological variation. Something in the range of 1 in 1,500 births results in intersex variation in which a newborn infant's body, physiology, morphology, genetics, any combination of things doesn't fit into our expected parameters of male and female. So what's socially constructed in this situation is not that there are biological or physical variations, but rather that we have over time as people put parameters on what is expected. So for example, how big does a clitoris need to be still be considered a clitoris? How big can a penis be and still be considered a penis? And if you look at some of the medical history and documentation, you'll find that actually there are set standards for what these sizes, lengths, hormone levels, things like that. And if an individual doesn't fit into those expected parameters that split people into male and female categories, they may be considered intersex or having intersex variation. So the last one, A. Awesome, asexual. So asexual is an individual who experiences little sexual or romantic attractionality. It's oftentimes considered what we call an umbrella term because it also sometimes includes the aromantic community, but not always. And so that definition may be different for different people. Asexual without sexual attractionality or having little sexual attractionality, and aromantic being having without romantic attractionality or little attractionality. And so a few other things that I just wanted to note quickly before we jump into the video we're going to watch is that the language that an individual uses for themselves is always going to be the right language, even though it might differ from best practice, leading practice, or inclusive practice. What I would encourage you all as practitioners and future healthcare providers to consider is how do you adopt language that is, one, reflective of the patient when they use language for themselves, but if they haven't self-defined or given language to you that's going to be affirming, to make sure that you're aware of and keeping up to date with language that is going to serve as inclusive language or serves red flags. So one of the things that I actually noticed when I saw the video earlier was the use of this term transgendered with the ED. For a lot of transgender individuals, hearing the transgendered term can oftentimes be a red flag. This is a person who might be less informed about the transgender community or less aware of kind of current best practices. And so I really want you all to be attuned to some of the language that the folks in the videos are using for themselves and recognize that's okay and that's great. But when you're talking to a broader audience, to make sure that we're always trying to adopt inclusive language whenever we can. And one final piece is the difference between sexual orientation, which is about attractionality. All of us have a relationship to sexual orientation, not just people who identify as LGBTQ. And so that's about who you're attracted to, who you want to date, maybe sleep with, etc. And gender identity is how you see yourself. So your relationship to the concepts of manhood, womanhood, non-binary identity, etc. Again, all of us have a relationship to gender, not just those who identify as transgender or gender non-conforming, etc. What's important to remember is not to conflate these two concepts. A lot of people make assumptions that individuals who are transgender have a particular sexual orientation, or people who are gay or lesbian have a particular gender identity. That may or may not always correlate, and so just when you're thinking about, like Grace said earlier, taking sexual histories, taking comprehensive information in, not to make assumptions that an individual's identity around sexual orientation is going to tell you about their gender identity. And I'm going to stop there, and I think we're going to pop into the video.
Okay, so, yes. Hello again, I'm Dr. Katie Barnhart. I use she, her pronouns. A couple of things to introduce to you before we dive into the video. One, you have all been given an index card. And if you've already taken notes on yours, there are blank ones kind of around you. You can grab one of those in just a minute too if you want. After the video, we're going to have some dialogue, as well as we are open to answering any questions that you have. And we'd like for you to ask the questions using that index card. So you do it anonymously, we'll collect them before we do the panel discussion, so some of it will be guided by the questions that you came into the room tonight with, or that you develop over our conversation before then. So, as we've introduced health disparities and given you some definitions, one of the things that we tend to talk about in relationship to health disparities are social determinants of health. Social determinants of health tend to be, can be individual, but oftentimes are systemic. So things that happen within someone's environment. The healthcare setting, healthcare system is part of that environment. So the video that we're going to watch today includes some first-person accounts of interactions that they had in a healthcare setting. And while we've introduced a variety of different things as it relates to health disparities and definitions, the video is going to focus primarily on transgender folks and their experiences, but our discussion towards the end can include LGBTQIA folks as well. So we'll focus here and then have a discussion, and then we'll make it more inclusive towards the end.
Transgender is an umbrella term that can be used to describe individuals whose birth sex does not align with their self-defined gender identity. For example, if a person is born female but identifies as male, or born male and identifies as female, they are transgender. Genderqueer Gender fluid and gender nonconforming are some other words used to describe people who may feel they are both male and female, neither male nor female, or a different gender altogether.
Transgender is an umbrella term in my language, in my experience, and it incorporates basically anyone who wants to identify as transgender. It's all about self-identity.
To me, a transgender person is a person who does not identify with the gender role that was assigned to their birth sex and may or may not take like a somatic kind of intervention against themselves. They may undergo some sort of physical transition, or they may just undergo like a social transition, or they may not.
There are people that strongly feel like, that they're trapped in the wrong body. But then there's also a lot of people who are genderqueer, gender fluid, androgynous, where maybe they don't align with one gender or the other. Maybe they reject gender entirely. Maybe they feel like they're both male and female or something in between. So there's a lot of gender diversity across the spectrum of trans identity.
I think anyone could potentially identify as trans, anyone who doesn't identify with the sort of restrictions that go, or the sort of baggage that goes with either being a man or a woman. So I think, there are lots of identities that fall in that. You could be transsexual, meaning you're sort of like changing your sex through medical or hormonal technologies. You could be just sort of mixing and matching clothing or hairstyles, things like that. You could be like a butch lesbian or a sort of more feminine gay man. A whole variety of things a variety of people could potentially identify as transgender.
Just recently I was introduced to the concept of mandatory pronouns as opposed to preferred pronouns, which I find kind of amusing. So my mandatory pronouns are he, because preferred implies there is some other option. I use male pronouns, he, him, and his.
My preferred pronouns are masculine pronouns. I identify as a trans guy, sort of gay identified trans guy.
I identify as a male to female trans person. I would call myself a trans woman, and I use female pronouns.
Pronouns are the bane of my existence. And the reason for that is because there just isn't language to adequately describe people like me. Most of my life, I've answered to feminine pronouns, she, her, and on some level, I always cringed every time I heard that. Now think about that for a minute. Think about what it would be like to internally cringe every time somebody directed a pronoun at you. And that's been the reality for most of my life. As I came to terms with my transgenderism and being trans, friends, good friends, started using male pronouns. And for a long time, that felt really awkward too. On one hand, it felt good, it felt refreshing, but it was also very strange because he did not really describe me either. So, what pronouns do I prefer? The short answer is I prefer male, but I don't demand it. Adolescence may be an especially difficult time in the lives of transgender people. As a teenager, the stress of dealing with a body that is incongruent with one's inner feelings can lead to negative health outcomes.
As an adolescent, I know my parents sort of picked and kind of prodded at my gender expression at the time. They weren't a big fan of it. So I know a lot of trans people kind of go through similar scenarios where they express something of what they want to express as far as their gender identity and expression. And people in their lives kind of tell them no. You can't wear that, you can't do that.
Adolescence was difficult for me because my stepfather was not comfortable with my early expression of identity, and I knew I had to hide it from him to avoid, I guess, sort of like kind of violent reprisals. And so I started seeing therapists for it when I was like 18, 19. And my therapist insisted that I be able to move out and become financially independent before she would write a letter for hormonal transition. And I think if parents don't accept their children's identities, then adolescence can be really difficult because you can be thrown out, you can be pushed out on your own, or, you know, you can just like have to leave kind of early, like I feel I did, to be able to be who you are and take steps that you need to be okay and healthy and safe and comfortable in your body.
Adolescence was a particularly tough time for me, as I think it is for a lot of trans people. If you think about it developmentally, adolescence, particularly early adolescence, we're all still in a place developmentally of concrete thinking. Things are black and white. And so consequently, adolescence is a time of real gender intensification. You know, boys are supposed to act this way and girls are supposed to act this way. Now that's always there from birth on, but it really gets intensified at about junior high age in there, where the girls really start acting like girls and boys get real macho, and the sexes really divide there. And so for a time in my adolescence, I tried to do the right thing. I started wearing dresses and makeup and going to school that way, and I felt absolutely ridiculous. It just did not fit me. And it really didn't help anyway, because people still made fun of me, people still teased me, because even though I was trying, I was still a guy in a dress. And even though people consciously couldn't put it in such concrete terms, they knew that's what was going on. So it's a tough time for trans people. And it's also tough because adolescence is a time when you're really trying to find yourself. Who am I? You know, what is it that I'm really about and I really believe? And we try on a lot of different hats and we try to figure out who we are. And what I am, according to society, does not exist. So it's a very difficult time for a trans person. Transgender youth may struggle to find the health care and mental health services they need due to the stigma and discrimination that can result from ignorance and misunderstanding. Medical professionals typically do not receive education on transgenderism or training on how to serve trans people. As a result, many feel especially uncomfortable discussing gender issues with young people.
The way that it's set up, at least to even access care as a trans person for being trans, is an issue. Just walking into a medical clinic for me gives me a lot of anxiety because I have no idea what I'm going to be asked or even how to fill out paperwork. I don't know if going into my endocrinologist, they're looking for me to write F or M because I don't know what they're looking at. Are they asking about testosterone levels? Do they really need to know, exactly what my chromosomes are, because chromosomes are problematic anyways. So it's a struggle.
A lot of physicians can be really insensitive. One time when I had a UTI, it required a swab because the physician was just dead certain that I had chlamydia. And he was really not gentle with me, and I told him I was a trans woman, and he said, "That's okay, man. I did my residency in New York. I've seen it all." So, and then, shoved a swab inside me, and I think that's the only time I've ever actually screamed involuntarily in pain in my adult life.
Because I sort of pass as a white guy and don't have to deal with a lot of other forms of structural, oppression and things like that. There are a lot of ways that transness doesn't sort of affect my daily life. But I think healthcare is the major piece that I feel like still really scares me. There are these stories from, Trans Day of Remembrance and stuff like this about, trans women of color in particular sort of being left by EMTs to die. And so I think the idea of having some sort of emergency medical situation terrifies me. I generally my general sort of interactions with healthcare providers have been around allergies, so it hasn't been a huge deal. But I'm not getting the sort of yearly checkups that I should be having because I don't really know of any doctors around here who I would trust with that sort of stuff, like whether you're feminist or sex positive or having some awareness of trans issues. I don't know of doctors around here who could do that. A friend of mine has made an appointment to go up to the Chicago Women's Health Center for, sort of gynecological care and asked me if I would go with her. And I realized, I should probably do that. I should probably make an appointment in some place that's more sort of feminist or queer positive or something like that. But I also realized that, even though I would sort of trust people there to be aware of my medical needs and not make, sort of transphobic or homophobic assumptions about my body and my sex practices, that still feels like it's going to be a very difficult experience at this point. And it's always sort of awkward to be having some sort of gynecological exam, but there's something about it that feels like a little bit traumatic to me. So I would be going there because I trust them.
I showed him the letter that I had from my therapist, and he said, "Oh, that's cute, but I don't really require a letter." And he saw my name and said, "Jane, is that what you want to be called? Okay." And he called me Mr. Waldrop a lot for the most part, until one day he came in to announce that my testosterone count was under 60. So when he came in to announce that my testosterone was suppressed, he called me Ms. Waldrop for the first time, and he indicated my breasts and said, "Are you happy with those?" And while he was listening to me with a stethoscope, his hand found one of my breasts, and he started playing with it and jiggling it and just sort of toying with it. And I blushed, and he said, "That's some pretty titty there." And I crossed my arms over my chest and docked a little bit reflexively. And he just said, "Oh, I'm sorry, are those still tender?" And I don't know what I said after that, but that was the last time I went to see him. I didn't have any further contact with him. I just went to see a new doctor in Austin. And later I got a letter in the mail from him saying that I was discharged from his care because we had no contact, which I guess was thoughtful of him.
There are all of these forms that just sort of make assumptions about the relationship between genitals and genders, right? So if you're talking to someone who has a uterus and you have particular questions about a uterus or a cervix or a vagina or whatever, you can talk about that without saying Lemon's anatomy or assuming that the person who has those parts is a woman, right? Most of the people you see who have those parts are going to identify as women, but some won't. And if they see that you have a form that removes those references to being a woman or having a particular gender, that opens up much more space to feel comfortable and have more honest discussions. So if there's any room for sort of evaluating forms and really basic language like that, that's really helpful. There was another unit there that was thinking about they had two separate sheets for the instructions for urinalysis sort of collection, right, for urine samples. And so instead of figuring out do I think this person has a penis, I'm gonna give them the instructions for if you have a penis. They were just gonna print them on two sides of the same paper and just give the paper to the person and let them look at the side they wanted to look at, right? So that helps, any of those sort of simple ways you can deal with the sort of forms and the paperwork to open up more space, I think would go a long way towards making trans people sort of feel more welcome and feel a little bit better in those spaces.
Something that I've found interesting is treating it less like a disease and more like a just sort of naturally occurring medical condition, like pregnancy, oddly. So the idea of kind of having that kind of similar thing, treating it as though it's a naturally occurring, which it is, just sort of amazing thing that happens on occasion. Just kind of treating it like that, it's completely normal, though normal is a loaded word. Sort of occurrence.
For people who would like to know more about transgenderism and how to be sensitive to transgender people, there's a lot of good information on the internet. The Kinsey Institute and the Kinsey Confidential website have hosted some wonderful pamphlets made by a person named Sky Brown that offers a lot of basic overview of what transgender means and how to be a good ally and be supportive of transgender friends, families, and people that you meet. So I would say do some research on the internet, and if you're directly interacting with a transgender person and you're not sure what pronoun to use, what name to use, if it's okay to ask this question or that question, if you just ask politely and respectfully, I'm sure the person will be able to meet you halfway with that.
I think there is a incredible lack of education that's done in medical schools. And I think the medical community, just like society at large, is woefully ignorant on these issues. And I think an awful lot of practicing physicians and nurses just don't understand this phenomenon. And like the rest of us, they've been raised in a society that says you're either one or the other. And if you're this, that means you have to be this way. And if you're this, it means you're this way. And as a society, we get very nervous around people who don't conform to that. And medical people often are no different. You know, they see what to them looks like a guy in a dress or a female who's being way too masculine, and inside they go, oh, what is this? You know, that's a response most of us have. Even as a trans person, as a young person, I had that before I really understood the nature of what I am. And so because of that lack of understanding, that lack of education, I think there's a lot of knee-jerk reactions that come from medical professionals. And it's directed at the transgender person. And we don't need it. We have enough on our plate dealing with who we are and trying to make our way in a society that says we're not possible.
Alright, so if you would, by yourselves for just a minute, 60 seconds, jot down, or you can think about it, you can type it in your notes on your phone if you want, initial reactions, things that stand out to you or that will be takeaway messages, and what you can do to maybe change some of these stories in the future in whatever role you see yourself in. So after graduation, whatever profession you're going into, what are some things that you can do to limit some of these things that were just given as examples? So brain dump. Either sit and think about it for a minute or jot it down, type on your phone. All right, so that was 60 seconds. Hopefully you have some notes and we're able to do a quick brain dump. What I'd like for us to do is share with one person, and what I know from experience is that we tend to sit with the people that we know, and since this is supposed to be interprofessional, what I'd like for you to do is find a partner across the aisle or who's not sitting directly next to you. So someone who you don't know, and share some of your initial reactions and what you think you can do in your future role. So find a partner. Oh, stand up. And if you're online, please, you can chat on there and do this as well.
I'm Taylor.
Like, what were your initial reactions?
What's your seat?
So just pairs, partners, two people. We won't have time for everyone to talk if you're doing a big group.
Wow. You did that?
I just made the arrangement.
All right, let's bring it back to the hole. Find your original seat.
Tap it to make it go back.
All All right, and some initial reactions. What stood out to you?
We're supposed to be confident and cultural and how everyone views themselves, and then going off of that value is just dumb. I just don't like that. It's just makes me want, well, I wasn't going to anyway, but it makes me more aware of being, hey, how do you prefer to be called? What do you want me to call you? Like, what do you want me to refer to you as today? Is something we learn about in nursing school. So. Yeah.
Moved us into the second part. So what are some things initially that you're thinking about that you can do in your future profession? Yeah.
And I think first and foremost is just treating them like any other human being, if that's what they are. I mean, I see them being like, to show them comfortable sometimes too. That's all they want is to be treated with respect. And, person. And again, like what Brendan was saying too, like farms and stuff, just ask. Like,
Others, what can you do?
Making sure that they understand that they are welcome in your care, in your office, and that we are human, that we may make a mistake and use the wrong pronoun, but that just apologize and that they're welcome and that we're trying.
Maybe one more person? How can you take action? Yeah, thanks.
Until things like the double-sided, urine sample test, until that's standard across the board, is getting those options without having to be asked. Just being aware that should be standard practice ahead of time.
All right, so if you all would, now is where we would like to collect your questions. So if you haven't been writing them down, take just a minute, jot down any of your curiosities, things that we can answer as a panel. We have some questions too. Okay, so I'll start with the first question while people are still passing them through. How can we, as healthcare professionals, make the healthcare setting more comfortable and more welcoming?
I can answer that, or at least a component of it. So welcoming environments is a really important concept for all of you to understand. And one of the ways you can do that is just walk into your healthcare settings, into your clinical sites, and ask yourself, if I was a gay person, if I was a transgender individual, if I was Hispanic, you can make that list as long as you want to make it, and just ask yourself, is this a place that feels comfortable? Are there symbols? Is there literature out? Is everything bilingual? Are there maybe rainbow flags? Are there pink triangles? Are there symbols that say to particular marginalized populations that they're welcome and it's an inviting environment to be in? And you can't just put up that rainbow flag, right? There has to be training. There has to be across the board a collective desire to make that environment welcoming to all people. So that question is pretty complex because there's a number of different levels. Individually, of course, treating every person that comes in with respect, but also from the system. What does this environment look like, feel like? And that has to be a collective initiative between everyone present. So doing the work on both of those levels is really important for creating the environment. But thinking about symbols is really important. This idea about putting, using an educational tool that is more welcoming to all people. Maybe many of us would have not thought of that, but it's essential to individuals coming in that feel this vulnerability and feel fear. That came up as one of your thoughts was, it's shameful almost to have people come in and feel fear. And these initiatives can be really, really important for those individuals.
I can build off of this because my pushback to this is usually that in healthcare settings, we should be universal regardless. There shouldn't be an us and them, right? So when they come in or us. Instead, if we think of it, like we have things like universal precautions. So we don't ask someone necessarily, they may not even know, right, their HIV status. We take all the same precautions regardless of whether or not someone is HIV positive. We can do the same thing when we're interacting with patients. Asking everyone their pronouns or asking that on a sheet. And then it's not just, oftentimes we poke at the medical providers, but in a healthcare setting, it's the first interaction that someone has when they walk into a clinic. It's the person who is taking their, their vitals and everything and updating their charts. So if we can start training folks to look and be intentional, right? So not just name on the chart, maybe pronouns are on the chart as well, and not necessarily legal names, so what's on their license, but the name that they use or want to be referred to as a patient within that clinic for everyone is something that can be helpful.
And one more thought is just doing your own work on using us and them and catch yourself when you do that. How could I refer to this scenario in a different way? And then one of the thoughts that also made me think about is calling individuals by their last name. Until there's a trusting relationship, but that's a way to treat everybody without being offensive or hurtful.
So building off of that, if someone identifies as they, what does that mean?
So they in and of itself is not an identity, it's the pronouns that a person wants you to use for them. So if a person introduces themselves and says, hi, my name is whatever, I use they, them pronouns, all that has told you is that when you refer to that person in the third person, that they want you to use they, them. So they went to the store, their patient, that is their chart, for example. It does not always indicate what identity they hold. Oftentimes it may correlate with a non-binary identity, so an identity that exists outside of the male-female binary. But again, every individual is different, and so we can't make assumptions and say, this person's non-binary, they're gender fluid, they're gender queer. It doesn't tell us their identity. All it tells us is that is the pronoun that they want us to use for them.
There's a follow-up question to something that was said earlier. So why is it difficult to collect sexual history in West Michigan?
I would throw that back at the students if I was doing this lecture, but being that we have to answer that for sure. West Michigan, I think as we all know, is based in some pretty tight cultural and belief norms. And this comes up in one of the classes that I teach, that many people are structured in a very traditional and conservative religious ideology. And on one hand, that can be very positive, right? The family structure, the values that people have are very clear and understood and feel safe. But then on the other side of that, it can also make judgmentals, statements, judgmental views on people that don't fit within that structure and within that belief system. So we have to look at that as a society and a culture and to say, wait a minute, let's understand, rather than making something right or wrong, but let's understand the output and the outcome of what that may do for individuals coming in that don't fit in that same structure. That's one thing. There are a lot of things. We know, for instance, I don't know how many of you know what PrEP is or prophylaxis. Raise your hand real quickly if you've heard of PrEP. Okay, so maybe a quarter of you. PrEP is an antiretroviral medication that you give 1 pill a day, very similar to the birth control, to reduce the risk of HIV. And I bring that up with this question because primarily our primary care facilities don't know about PrEP. There are CDC guidelines that say exactly what we're supposed to do in a healthcare setting, and they're ignored. Many individuals within this population will call their primary care provider and be told, we don't do that here. We don't prescribe that here. So we have to think about, okay, what does science tell us? What does the evidence say? What are the CDC guidelines? And we have to practice according to that regardless. And we have some barriers with that. We all have to collectively come together in healthcare and transcend. So those are two areas that I can think of, but like many things, there's a lot of factors that play into that.
I don't think we can ask. Did anything else come to mind when that question was posed? If you should flip it to students, why do you think it's difficult to do sexual histories in West Michigan?
I mean, recently the whole learning answer, people just might be more in tune to like sexual misconduct, and they might be more nervous about that.
Me Too campaign brings up an awareness.
So one of the things that's mentioned is someone noticed that we were using folks a lot, and they want to know if this is a more gender neutral word that is widely used in the LGBTQIA community.
I know for me, one of the reasons I adopted folks and sometimes y'all, I grew up in Michigan, and it's a very common Midwest vernacular usage of the term you guys. And because guys is very much a gender term, not everyone is responsive to it. And so for me, that is a really intentional choice in my language to use folks, people, y'all, to try and keep it more open so that every single person can see themselves in that language.
Yeah, me as well. So I found myself in grad school in a space that was very aware of the language that we use, and started to notice that more folks were using the term folks in that setting, and had some conversations with people around why, and also adopted that language for myself, something that took time. It's not something that happens overnight to change your initial way of talking about a collective group, but something that's more inclusive, that we can work towards using that kind of language. And I think it took me a while because I thought it felt very Bugs Bunny, is what I always say, which is fine. Bugs Bunny was inclusive at the end of the cartoon. I don't think a lot of folks know who Bugs Bunny is anymore either, because Bugs Bunny is not super popular anymore.
I know.
So in your experience working with patients, and these patients who are uncomfortable due to poor experiences, how do you regain trust? This is a hard one. So in your experience working with patients, and these patients being uncomfortable due to poor previous experiences, how do you work on regaining trust?
So I can comment on that a bit, and that in Grand Rapids now, it's new, but we have an LGBTQIA healthcare consortium. And what that is all the healthcare institutions come together. We meet once a month. And one of the most powerful things is that people come in and share their stories. And so we hear this theme over and over again. A lot of transgender individuals going through ER, that's a real crisis piece where some situations can occur, and a lot of damage is done. So we know that. I think acknowledging that damage was done, and that has to be respected, and those stories have got to be listened to. The other piece that comes up is I've told my story, and then nothing seems to happen. It was heart-wrenching for me. I reported it, no outcome. So this idea of, rather than just listening to the story, which is so important, is taking the steps to follow through with the system, which is the difficult part, right? That you keep going with it. You keep the messages coming through the system to see where we can either collect this data and do something and have some interventions to follow through with the data, and to give people feedback, right? Professional feedback, that their voice is very important. Those are two things that I have heard.
Yeah, and I'll just add, I think, a sorry can go a long way, but one of the most powerful ways that we can really demonstrate that we are apologetic is to make sure that we change our behavior. There's oftentimes when folks are misnamed, mispronounced, or some other part of their identity is disregarded or, right, belittled or made light of, if it happens again and again, even if we say we're sorry, that relationship is not going to be repaired. And so I think that that's a really huge piece. And I think as somebody who doesn't provide healthcare but certainly experiences it, I think that another piece that can be really valuable is recognizing your own limits, and also if you are not able to serve that patient. There is significant harm done when folks simply don't have the tools or willingness to serve all patients. If you know that that is one of your limitations, one of the best things you can do is find somebody who's going to serve that person better.
So the next question is kind of picks up on something we talked about earlier. Is identifying as intersex just based on the size of someone's genitals or individually decided?
So intersex variation has, as the term might suggest, a lot of variation, right? And so this might be an individual whose physiology, for example, does not match their chromosomes, or they have a combination of genitalia that would be traditionally assigned to folks who are male and female. It can be something as detailed as a urethra that does not exit at the tip of the penis. So intersex variation really covers a really, really wide gamut of biological variation. I really encourage you all. This is one of the areas that the medical community has not spent a lot of time talking about when talking about the LGBTQIA+ community. It really is widely varied. And the more we learn about intersex variation, we're learning that there are a lot of individuals who are not aware that they're intersex, for example, because their external anatomy and their hormone levels may match what people expect to be, for example, female, but they may have XY chromosomes. And so there's a really, really wide range of experiences.
Yeah, and chances are that if you're in the healthcare field, you will come in contact with families, with infants, that this issue is present. It used to be, when I was practicing at the majority of your ages, I'm guessing, that we had to gender that baby right away. There was not a question about it. The family wanted that baby gendered, and we would do whatever. So when they left the hospital, that baby had gender. And that's starting to change. We're looking at the literature and the evidence now, and that's not so true. You know, the child, the infant, does not have to be gendered right away. And as a matter of fact, some of the outcomes from a mental health perspective say it's healthier to not do that. And again, you need a supportive, well-educated family. But that's where healthcare, that's where nursing and all the health professions can have an impact. Look at the literature, what's the latest, and help to educate your team, your healthcare team on this. Because I totally agree with Jen, it's not talked about. It's kind of an invisible issue, and it needs to be in the forefront of healthcare. But that is definitely changing over the last 20 to 30 years.
How do you think we get parents to buy into that? Because folks are very used to hearing, right, it's a boy, it's a girl.
Right.
And when someone isn't identified one binary gender, right at birth, then it turns into this social emergency, more so on the parent side.
And that would be another thing to think about. We're here for interprofessional, right?
Mm-hmm.
You don't make those decisions and those assumptions on your own, because that's a complex entity in today's world. So you bring in social work and want a social work that is adequately prepared in intersex. You bring in physicians, endocrinologists. An endocrinologist is an important person, but one that is doing work with the transgender population. We have them in Grand Rapids now. Okay, so the idea is to connect with other professionals to get the best outcomes for that family, for education, and the patient. And there's, I don't think, a parent alive who doesn't want the best for their child. And the professional healthcare team can help guide that family with the appropriate education for that.
So how would you go about having a conversation with another professional who's outwardly negative about the LGBTQIA community?
Let me try that one. First of all, everybody needs to know where they're employed, what the mission and the vision is of their institution. So we're getting more and more very inclusive with missions of our institutions. So Spectrum Health just had a training for SOGI, which is sexual identity, sexual orientation, gender identity. They just had a SOGI training for 30,000 of their employees in the immediate mandatory. Some of you might have even had to take it if you're employed at Spectrum, absolutely. So this idea of training and mission and vision, really important, because guess what? If someone makes an offensive and biased comment that is your peer, we come back to the vision and the mission. And if you are paid by that institution, you must abide by the mission. And that is an argument you can use for families, for people coming in, for visitors, and for peers. That's a pretty simple definition for a pretty complex relationship, and you might not be prepared to do that as a novice person coming into healthcare. So again, you look at your team, you look at management, you look at the individuals around you, and you don't make this decision on your own. But you also don't address this and let it, fall off. There has to be some follow-through, some action, and Jen alluded to that too, a change in behavior. And those are the pieces that need to be followed through on.
Yeah, and I'll add on to that a little bit to say, I think relationship matters, right? If this is a colleague that you have a really good relationship with, I think there's an opportunity to start from a place of best intent. I know you care about patients, I know you care about health outcomes, and what I notice is that some of your language, some of your attitudes, behaviors, make it in the way of that, right? Grace provided a lot of different examples of how do you bring it back to the mission and vision of the organization, but also the work. I deeply believe that people get into this work because they care, right? They want to see people served well, and a lot of folks hold ideology that is harmful to marginalized and historically underrepresented communities, that they don't realize the impact of their actions, their behaviors, words, and sometimes one of the things that I think is really helpful is to ask that person, if you knew you were creating harm, would you consider this? And that is oftentimes a place that is so powerful for us to start at just as people. And again, if that person has deeply held convictions, and that's a reality in all of our work for many, many identities, how do we help that person, right, reduce the harm that they're creating? And maybe one of the best things we can do is how can we make sure that you're not getting in the way of somebody's best care, right? Can you pass on patients who you know you're not going to be able to serve well? Sometimes that doesn't sound like an ideal situation, but how do you serve them better? And again, there's a lot of great education out there for folks to explore their own identities and to understand why their behaviors are getting in the way of them providing the best care.
I just want to take a minute and check in with everyone. So if someone has a new card at the end, will you wave it for me so I know I need to get up and come get it? Ooh, okay. Okay. So the next question asks about other areas in healthcare where people of the LGBTQIA plus community might have the most trouble. So we saw some examples within the documentary today. Other things that I've heard documented from individuals, right, is this idea that if they're going in for a cold or the flu, do you really need to know about someone's genitals? So going in for the cold or the flu and then being asked questions about someone's sexual identity or gender identity isn't necessarily something that we need to know to help them with some of the symptoms that they have at that time. Additionally, some of the things that are documented within research for folks who, women who are only having sex with other women, is that when it comes to things like pregnancy prevention, especially among young women, one of the common occurrences is that they're shamed when they go into the doctor and ask questions about their sexual history, that they say they're sexually active, but not using any kind of birth control or prevention in terms of pregnancy. And this happens repeatedly, so they'll go into the doctor one time and they'll get shamed, and then go in the next time and get shamed. And they have to explain themselves each time that, well, I'm only having sex with other women, and pregnancy prevention is a part of that with my current partner. I don't have to worry about getting pregnant. But it's the having to talk about it each and every time when it can be documented in a medical chart, and we can do a better job of making sure we go back so that we're talking with that patient based on what we already know, so they don't have to keep having the conversation over and over, because that can be a barrier to continuing to seek care.
And one of the things that comes to mind here too is that a number of individuals in this particular population, if they have a bad experience, they're not going to go back for preventative services or for primary care services, unless there's a crisis. So we see a higher percentage coming into ER with situations that could have been prevented. So we look at mortality rates for breast cancer among lesbian women. You think about what might that be? You know, if they've had a bad experience, even if it was something that happened for a broken foot, they don't want to come back into the organization for mammography, for pap smears, or other things that may have a big impact on their life. So we do tend to catch things that are preventative or early detection at later stages for individuals too. So it has a sort of long-term chronic illness effect.
Cervical cancer as well is one of those areas where we see health disparities. Because oftentimes providers who do recognize that a woman who's having sex with another woman don't always have those conversations, so the women themselves don't realize that they have to be screened for STIs, or that they should be screened for STIs, or even are at risk for STIs.
And prostate cancer, right, trans women, there's some screening for these individuals. So that we see, again, prostate cancer found at various stages, if it is there. And another thing just to think about real quickly is when we look at transgender individuals, they haven't necessarily gone through hormones or surgery. There's a vast variety of how people deal with their identities. Okay, so there's an assumption that all people will be going through hormone therapy and through surgery, and although that might be somewhat of an ideal for some individuals, for other individuals they may not choose to for whatever reason. So again, going from that individual and what their needs and perspectives are really important.
So the next question, the person thought it was off topic, but I think it totally aligns with what we're talking about as well. So what do you suggest about how to go about raising a child in a non-binary way? So how can we, raising a child, since some of the binary gender ideas inherently in them. I'm thinking, asking about just, so what do we do to break the binary from an early age?
I'm not sure this is the intent of the question, so please address it. But we do know what estrogen and testosterone do, right? They do have an influence on behavior, on perspective, on all kinds of things. And levels of estrogen and testosterone definitely play out in behavioral ways, if not in physical, biological ways, right? So we do know, and I think this inherent question is, what do we do with this if inherently a person is one way or another? I think it's the perspective that you look at from a parental perspective. So the education to a child about pronoun uses and about what is the difference between how you might be acting related to estrogen compared to how you might be acting or responding to things based on what culture tells you should be. And starting those conversations really early based on the child's developmental level, really positive. It helps to open their world and open their communication with people they may not have otherwise. So I'm not sure that's where you're going, but that was my first thought.
Yeah, I was reading a really interesting study recently that talks about the impacts, like Grace was talking about, around estrogen and testosterone, and And what's really interesting is that a lot of what this article is talking about is that the variation within sex assignment, so among all males assigned at birth, is actually just as wide, if not wider, in terms of experiences and how that plays out in their affect, as it is the variation and how wide it is between men and women. And so I think that it's helpful, right, as part of the ways that we think about binary identities and also how our culture has structured it, to understand that it's also perspective, right? How we have sorted things into a category, male and female, as intrinsic and naturally always existing in a binary, when we know that, for example, intersex people have always existed, right? Even our language around intersex variation has changed dramatically over the last few hundred years. And so I think part of it is also helping us re-signify the ways in which we've understood variation, and we can see it as abnormality, or we can see it as, right, natural variation that has always existed in the population. And I think that particularly children have a really amazing ability and capability of understanding developmentally appropriate concepts at a young age, right? To understand that there may be men and women, and there are also individuals who identify outside of the binary. I work with a lot of young children that when you introduce this idea, it really makes sense to them if they've met somebody who is non-binary or somebody who identifies as genderqueer, because there's an authentic audience for them to understand that this is another human being, a person that they can relate to and understand that this is just part of the kind of complexities of the world around them.
And I think early on we can push back against some of the social things that exist within environments. So you can even ask a 3-year-old and they can tell you which things are for boys and which things are for girls. And a lot of that is learned from their social environments growing up. So if we push back at that with kids, so even when we think about stores, when you go to a store, there's a boys department and a girls department, but maybe just letting the child pick from either department, or not as a parent going to one specific department, but maybe buying from both. So breaking down and pushing back against some of those things that exist within our society to define gender that don't have to. Let's do this one next, so it kind of goes along with that. So if a parent of a young child seeks medical advice about their child who identifies themselves differently than their assigned sex, how do we respond? And they say, for example, if the parent is wondering if they should legally change the child's name, what advice should be given?
So we do know, and Pediatric Association, the Pediatric Medical Association of the United States has clear guidelines now, right, for hormone replacement therapy or hormone adjustment therapy for children as young as 4 years old that identify as not sort of the gender dysphoria or not comfortable with the gender that they've been sort of told they are. So we do have these guidelines now. So in this situation, I would absolutely have this child and his family involved with a medical professional in endocrinology that doesn't necessarily, there's a real apprehension for starting children in the protocol at an early age. And there's a lot of pushback in the medical community on that as well. But we're starting to collect the data that says adjustment-wise, the earlier you start with treatments and with hormone replacements, the better off this individual will do, not only physically, but emotionally and from a mental health perspective. So again, that dialogue is really kind of a tense one, but we do see in areas that are a bit more progressive that it's a more accepted thing to look at. But we have now a couple endocrinologists that are really good right here in West Michigan. So I would absolutely look at that as a part of what may be a piece of what this particular family may or may not be.
Yeah, and I would echo that. Part of the standards, there's a great acronym PIC, so persistent, insistent, consistent kid, that talks about an individual or youth that is persistent, insistent, and consistent about the gender they say they identify as. And so there's really great data out there. It's still not as robust as I think it could be in terms of best practices around serving trans youth. Hormone blockers are oftentimes an alternative that is an intermediary to hormone replacement therapy that we see a lot in West Michigan for parents who say, I just want to buy a couple more years for this child to be a teenager or a little bit older to make sure that this is something that they really want. It buys time, right? So there's a lot of different treatment protocols and it's really making sure that we're aware of what the standards have out there available to us. And then on the social affect side, there's a lot of really phenomenal literature that folks in the social sciences are developing. For example, out of California, there is, the researcher's name is Caitlin Ryan, and she has done a lot of research over the last 15, 20 years around protective factors that can actually minimize some of the social and health disparities that LGBTQIA plus people experience. And a lot of that information is really helpful for parents, and the research that she's developed has really shown that kids in particular that come from LGBTQIA plus supportive families are less likely to engage in risky sexual behavior, drug and alcohol use and abuse, as well as having lower incidences of depression, anxiety, and suicidal ideation. For a lot of families, knowing that the social outcomes can be impacted by their own behaviors is oftentimes a really helpful place to start, to know that their support can really strongly influence how their child ends up being safe in a lot of different ways that safety can manifest. And so some of that literature I think can be really helpful if parents are resistant or just not aware of really how those decisions early on will impact their long term.
Just one more, oh, were you going to say something? No? Just one more thought on that while Jen is talking is thinking about when you're in the healthcare settings and with adolescents. So we do know there's sort of this moment in time if the family, as Jen was alluding to, is not supportive and kicks that individual out of the home. Clearly, you can almost predict what happens if the literature goes back up, their mental health issues, suicide attempts, just start to skyrocket. So your education with families in what we know, what the evidence does, actually I should say what significance is shown in the literature out there, really important to add that to your education with the families because it's a critical time for many adolescents.
So the next one, I want to take just a minute and flip it on all of you because I'm imagining that everyone in the room, either in a professional context or just as an individual, has had some kind of interaction or experience in a healthcare setting. So the next question has to do with how healthcare clinics are doing as far as adjusting forms and policies to be more inclusive of LGBTQIA plus folks. And if you remember earlier, I argued that it shouldn't be an us and them, it should be like, what have you noticed, regardless of your identity in the healthcare system? How do you think we're doing? And what are some examples of things that have maybe gone well so far in your experiences? Maybe work in a setting where they have an example of a healthcare provider who has done something inclusive?
Yeah, I'd say like in like the setting I work in, we've had view like transgender kids and everything that we've done with the spectrum, we've done that online training has been very helpful, and even in with report from me as a tax tech and also from nurse to nurse, doing a good job of explaining what the kind of situation is, so right from the get go, the nurse can go right in knowing the pronoun kind of whole situation and make them feel as comfortable as possible right away. And in that situation, doing a good job of that. Small.
Thanks. Others?
think they recently, for Spectrum Health, they updated the electronic health record to include gender identity on the tracking board so that, this is for the emergency department, so it has their, assigned sex at birth and then their gender identity right when they sign in. So, you can know that before you even talk to the patient when you walk into the room. So I think that's been a positive move, but then I also have seen in some instances where it doesn't get updated or changed. So the patient identifies as one thing, but it still says their sex is male, they identify as male, but then when you meet them, they say they identify as female. So I think there's still room for that to change.
Anyone else?
Not in a work setting, but in our curriculum, the way we're taught to get a sexual history, any background information, any history taking by a patient, we're taught so much that it's like almost robotic, the way we're asking the exact same questions the exact same way for every single person we encounter. And I think our professors and our curriculum have done a good job at making sure that that's inclusive language when getting the history. And like in the first semester, that was a point that was made that you might not think of asking the questions in a specific way, but think about it from a different perspective. So it's not an example from the real world yet, but it's nice for the future of this.
Anything else you have to add? Oh, yeah, thanks.
I went to a Lipid Diversity conference last year with some staff at a small clinic that I volunteer at, and what we learned from there was we went back and looked at the forms and how they had formatted their forms. It was like male, female, and other. So we made sure, to change that and remove other, because what we learned was nobody wants to be seen as other. So.
So it sounds like there's some change happening, maybe over the last 5 years, but we're getting there in some setting. Any other examples?
Well, I wanted to address the policies. How exactly was that worded? Okay. What you're seeing at Spectrum is really, really important, because what we see is change on the highest organizational level. If you don't have that, it's very, very difficult to implement change. So we're seeing this right in front of our faces, which is really great for you to look at. So there is now an LGBT strategic health planning team at Spectrum. And right now it's primarily physicians, but we need to get other health disciplines on that, around that table, right? But you're going to see that now. So now the change occurs. And that's really important to realize, that you have to have the infrastructure and the overall messages for it to come down to all levels. And you're absolutely right. There's a lot of work that needs to be done in that area, but this is a really good foundation for it to happen.
So the final question, I think, is a great way to wrap up as well. So someone asked about the LGBTQ Resource Center and if it's on the Allendale campus, or what groups or other events might exist for students.
Yeah, great question. So thank you for whoever posed this. There are many programs and events the LGBT Resource Center organizes over the course of the school year that are open to anyone. For example, we have open door discussions that are monthly discussion series that are actually led by our phenomenal student workers. So it's peer-led conversations on a variety of different topics. Our evening programs, First Year Queer Alliance, Loud and Queer, are open to LGBTQIA+ students as well as allies who want to get more involved, connected to the community, but also learn about ways that we can be better advocates to each other and folks of other marginalized identities. And we also have a lot of great programs that are annual programs, including our Transgender Day of Visibility, National Coming Out Week, and our Transgender Day of Remembrance keynote speakers. So the events are annual, but the speakers change every year and are opportunities to learn more in-depth information about those communities. And so lots of different ways to get involved. we are rounding out the end of the semester, and so we've only got a couple programs left. But definitely for those who are returning, there's a lot of great events. They're all on our website, which is just gbsu.edu/LGBTRC. So if you're interested, definitely connect with us. We'd love to get you more connected in. Inclusion and equity as a division is also hosting downtown space on the Q campus in DeVos C. Tuesday, Wednesday, Thursday from 10 a.m. to 3 p.m. All of the social justice centers are rotating through that space to make sure that we have more connection to the downtown community, knowing that a lot of our pre-professional students are down here. So if you haven't yet, that's a great opportunity to meet the other social justice centers, and we are downtown every single week. The LGBT Resource Center is downtown 10 a.m. to 2 p.m. Every Thursday.
And tomorrow is Spectrum Health. They're having transgender awareness for healthcare workers, and that's from noon to 1 over the auditorium at Spectrum Health, if you're interested in that as well.
Thank you for all of your questions and your curiosities.